Beginning with our new topic, the most important one, that is glaucoma. Glaucoma, we'll study about the basics and the investigations of glaucoma in this session. So, what is the definition of glaucoma? So, basically, it is progressive and characteristic optic disc changes are seen in glaucoma. First of all, it is progressive. Optic disc changes are seen in glaucoma. It is a irreversible visual field changes are also seen over here. So first, optic disc changes. Second, irreversible visual field changes are seen over here. And then the third most is intraocular pressure may be raised or maybe not. Okay. In majority of the cases, the intraocular pressure is raised, but it could not be also. Okay. So the three things: optic disc changes, irreversible visual field changes, and intraocular pressure rise may be seen, may be not seen. Okay. Now, the optic disc changes are investigated by or tested by ophthalmoscopy. Okay. The irreversible visual field changes are tested by perimetry, and the intraocular pressure changes, the rise or the fall, is checked by the tonometry. Okay, so these are all the tests which are done for respective. Now the next thing which we are going to see is flow of aqueous. So the basically the fluid fill inside the eye, what is the flow of that aqueous? We have previously discovered that the ciliary processes are the one which are responsible for the production of aqueous humor. Okay, now so basically talking particularly, where is the site of production? It is non-pigmented epithelium of ciliary processes. This now the flow, the site of production, 70% is active secretion of aqueous, 20% of aqueous secretion is ultrafiltration, and 10% of the aqueous secretion is osmosis. Okay, so these are the different types of processes by which aqueous is produced. Okay, or you can say filtered out by these all processes. Now learning about the flow of the aqueous humor. So basically it is produced by these non-pigmented epithelium of the ciliary processes. Okay, then it is secreted into the posterior chamber. Okay, so remember from the posterior chamber the aqueous is coming to the anterior chamber into the pupil. Okay, so from the posterior chamber it is going to come to the anterior chamber via pupil, then via the anterior chamber it is going to angle of anterior chamber. Okay, it is going to angle of anterior chamber, also known as iridocorneal angle. And iridocorneal angle, the name itself tells us this is the angle which is known as the iridocorneal angle. Okay, the angle between the iris and the cornea, this angle is known as iridocorneal angle. So basically it got produced, then from the posterior chamber it moved into the anterior chamber, and from the anterior chamber it got into the angle of anterior chamber, also known as iridocorneal angle. Okay, now after coming to the iridocorneal angle it is going to get outflow. Okay, it is going to get an outflow, okay, via this. Now the outflows are of two types. These are trabecular outflow and the uvosacral outflow. Okay, the trabecular outflow has the trabecular meshwork. Okay, from this trabecular meshwork this outflow aqueous is going to travel to the Scamens canal or the aqueous vein. From this Scamens canal or the aqueous vein, it is going to episcleral vein, where it will be drained into the cavernous sinus via ophthalmic vein. So basically, you can just identify that if there is an infection over this trabecular meshwork, the infection is going to travel to the cavernous sinus via this route. Okay. Now coming up to the uvosacral, which comprises of the 10 part of the outflow of the aqueous humor. Okay. Now the uvosacral, it drains into the supraciliary part. Okay, and this drains from the space between the sclera and the ciliary body. This is nothing but this supraciliary space. Okay, the space between the sclera and the ciliary body. So it drains from this. So major portion is drained by the trabecular meshwork. Okay. Let us see an image for trabecular and uvosacral outflow. First for trabecular. So in trabecular, first comes the trabecular meshwork. Okay. Here you can see the trabecular meshwork over here. This is the trabecular meshwork, which is going to the Schlemmens canal. Then Schlemmens canal, it goes to the aqueous vein, which goes to the episcleral vein. Okay. And from the episcleral vein, now it will go to the cavernous sinus. Okay, so that is the outflow. Now here you can see this is the space between the sclera and the ciliary body. Okay, supraciliary space. Now what all are the types of glaucoma which we are going to study? These are open angle glaucoma and obviously closed angle glaucoma. In open angle glaucoma, the pathogenesis is in the trabecular meshwork. Okay, so to the trabecular meshwork, which you can see over here, this is blocked or there is an obstruction. So what is the treatment for open angle glaucoma? It is trabeculectomy. Okay, very simple. Now comes the close angle glaucoma. The pathway or the pathogenesis over here is due to iris. So you can clearly see this iris has got to the attached to the corneal surface. Okay, this. So in the normal image, you can see over here this iris was not attached to the corneal surface. Okay, but over here it is attached to the corneal surface at this part. Okay, and due to which the angle which was over here, this angle is now blocked. This angle is now blocked, so the outflow pathway is now blocked. So the pathogenesis over here is in the iris part. Okay, it is due to iris. The iris itself has blocked the trabecular meshwork. Okay, what is the treatment? So obviously if there is a defect in the iris, so we have to do iridectomy. Okay, very simple. Here is the classification for the glaucoma: open angle and the close angle glaucoma and their subtypes. Now what the important point is over here is investigation point of view. Okay, so investigation via tonometry. Okay, now tonometry, as we studied, it was used for intraocular pressure measurement. Okay, so the normal intraocular pressure is 11 to 21 mmHg. Okay, 16 plus minus 5. Now the intraocular pressure has a diurnal variation. Okay, and it is maximum in late mornings from 8 a.m. to 12 noon. Okay, and the type of tonometry. So basically we are going to discuss the types of tonometry. These are digital tonometry. Digital doesn't sense of digital like upgraded instruments or something like that. No, the digital tonometry, that denotes about that you have to use your digits, your fingers. Okay, and we are going to palpate the eye. Okay, and we are going to measure it. So via palpating, if the intraocular pressure is low, the eye will be soft. The intraocular pressure, if it is high, it would be rocky hard. Okay, it would be hard like a rock. If the intraocular pressure is normal, then the eye will be firm. Okay, normal, soft, firm, as simple. Now the DT is the technical technique that is choice for the patient wearing keratoprosthesis. Okay, so if the patient is with keratoprosthesis, then the technique we will after digital tonometry, the another method which is, that is indeterminate tonometry. Indeterminate tonometry is further subclassified into two types. These are Scleot's tonometry and rebound tonometry. This Scleot's tonometry, it has high displacement tonometry. So it is a high displacement type of tonometry, but the choice for self monitoring of IOP, intraocular pressure, is rebound tonometry. Okay. Now coming up to the Scleot's tonometry, this is the gadget used for Scleot's tonometry. So first we apply the 5 gram, then 7.5 gram, then 10 gram, and then 15 gram respectively. Okay, if it is normal, then we will apply 5 grams. Okay, the displacement of aqueous when the weight is put in, it would be in this direction. Okay, in this direction. So the reading shown in the Scleot's tonometry is covered into IOP using the Frandwell's nomogram. Okay, that is important. Okay, so the reading which is shown in Scleot's tonometry, it is converted into the intraocular pressure using the Friat's nomogram. Okay, now not a good tonometer. Okay, this Scleot's tonometry is not a good tonometry because the inter observed and intra observed variability, these are different. Okay, so it has both inter and the intra observed variabilities, so that is why it is not good. Now the next tonometry which comes is applanation tonometry. Okay, also known as AT. So applanation tonometry, it is based upon the Umbert Flick principle. Okay, important thing, it is based upon the Umbert Flick principle. And what is the formula for this? So P equals to F by A. Okay, pressure equals to force by area. Now the Umbert Flick principle is further based on two things, that is fixed force AT and fixed area AT. Okay, so on the basis of force and area we have classified into two. On the basis of force, the example is Macloff's and Barraquer. Okay, and on the basis of area, it is Goldsman 80. Okay, we'll study all of these examples. Okay, don't worry. So what are the examples for fixed area 80? These are Goldsman 80, Perkins 80, Mackemax 80, pneumatic 80, and Pascal 80. Now, Macloves and Barraquer, these are not used nowadays. The used ones are fixed area 80. Okay, so let us see the Goldsman 80. So Goldsman 80, what is in Goldsman 80, what is it is used for? So basically it is used for intraocular pressure measurement, and it is a gold standard thermometer. Okay, important, it is a gold standard thermometer, Goldsman 80 and gold standard thermometer. It is slit mountain instrument. Okay, it is a slit mountain instrument, or you can call it as a lamp instrument. Okay, it looks like a lamp. There is a cobalt blue light which is put into the eyes, okay, via the biprism and slit lamp. These are the structure. Or you can call it as a lamp, or you can call it as a orchid. Okay, so it looks like a lamp, or it's look like a orchid. Okay. Now, what is the method to measure the intraocular pressure? By the Goldsman. So topical anesthetic at the cornea is given first. Okay, then via the fluorescent dye we are going to stain the cornea. Okay, after staining the cornea there would be a biprism in movement forward to the torch cornea. So after staining we are going to put a torch on cornea, and that will show illumination under the cobalt blue light. Okay, as we studied. So basically after staining the cornea via fluorescent dye, we are going to put light or torch on the cornea, that is cobalt blue light. Okay, here in this image you can see this cobalt blue light which we are putting after staining on the cornea. Okay, then the biprism splits light into two semicircles. Okay, so you can basically see two semicircles. How these semicircles are arranged, we'll see. Okay, so the force adjustment till the inner margin of both just touches each other. So it means these are the two semicircles. Okay, and when the both the margins of these two semicircle touches each other, at that point we will mark the reading. Okay, so you can see in this image, in this microscopy, where both the semicircles are touching their margins over here. Okay, now the applanation area is fixed, and that is 3.06 mm diameter. Okay, and this is the wrong condition, this is also wrong condition, this is the normal or correct method of Goldsman 80 when the two semicircle touches each other. Now another method that comes is Parkins 80. So the first we studied it Goldsman 80, now Parkins 80. Parkins 80, we have a gadget, and it is an hand help instrument. Okay, in Goldsman we used to take the patient to the instrument, but this is the instrument, it is an hand held instrument. Okay, we can carry this instrument very easily. This is a choice of tonometry in children's, okay, in bedridden patient and in anesthetic patients. Okay, the patient who has given anesthesia before the operations. Okay, so in these all conditions we can measure the intraocular pressure via this instrument. Okay, Parkins 80. Now the Marget, that is a choice in irregular and edematous cornea. Okay, so when there is an irregular or edematous cornea, then Marget is the choice. Okay, this instrument. Now pneumatic 80 is used in for continuous intraocular pressure measurement. So if you have to measure the intraocular pressure continuously, then you can use the procedure pneumatic AT. Okay, the intraocular pressure measurement through contact lenses. Now the next method comes is Pascal's AT or dynamic counter testing. Okay, in this method there is no influence via corneal thickness, and it is the choice of intraocular pressure measurement in post LASIK cases. Okay, very important. In post LASIK cases, the choice of intraocular measurement is what? Pascal's AT or dynamic continuous treatment. Okay. So if after the measurement of intraocular pressure the corneal thickness is thick, then the measurement of intraocular pressure is false high. Okay, and if it is thin cornea, the measurement is false low. Okay, now the next comes is non-contact tonometry. We can use method like Grolman's tonometry or air puff tonometry, and this is a choice of measurement in screening of glaucoma. Okay, so in the screening of glaucoma, what is the choice of measurement of intraocular pressure? It is Grolman's tonometry or air puff tonometry, in which we use air jets to measure the intraocular pressure. Okay, now the next tonometry which comes is Rachel's Ocular Response Analyzer, okay, ORA, and in which air is passed on the cornea, and that is used for measurement of intraocular pressure. Now the transpalpable tonometry. Okay, so transpalpable, trans means from the outer surface itself, so we will be palpating from outside on the eyelid. Okay, so transpalpable tonometry, through the eyelids we are going to be palpating, and these are the two types: Dalton's tonometry and ProView tonometry. Now the next comes is previmetry. Okay, previmetry. So visual field examination is done by the previmetry, and it is used measuring by only 30° of the visual field. It is of two types, kinetic and static. Okay, the kinetic, in which moving object is used, and in static the object is static from one place to another. Okay, in kinetic we use Goldsman's perimetry, and in static we use Humphrey field analyzer. Okay, let us see these both. So this is an Humphrey field analyzer of static one. Okay, this machine, in which the patient sits over here and he observes different colors statically. Okay, so it is a blow type screen, and testing pattern is 2 to 24 to 2 and 30 to 2. Okay, so the central 24° visual field is being tested, and the central 30° of the visual field is being tested over here. Now the testing strategy for this HFA, that is supra threshold screening. Okay, supra threshold. Now the threshold is monitoring glaucoma patients. Okay, the threshold is monitoring glaucoma patients. So the first strategy, that was supra threshold screening, threshold monitoring glaucoma patient, and the third category which is used is SITA, that is Sweden interactive threshold algorithm. Okay, and this is the most common one technique used. Okay, now there are some newer techniques also, and that is swap. This is blue on yellow stimuli. Okay, so blue on yellow stimuli, and this test is known as conicellular pathway. Okay, so there is a blue and yellow stimuli, and this is used to test conicellular pathway. The second comes is the FDT. Okay, and there is a flickering black and white stimuli. Here it was blue and yellow stimuli. Here it is black and white stimuli, and it is used for screening in infants and children. Okay, and the test in which it is used is magnocellular pathway. Here it was coniocellular. Here it is magnocellular. Now the next comes is optic disc examination. Now it is done by ophthalmoscopy, which is directly done. Okay, it can be done by slit lamp examination, that is usually a 90-degree plus diopter convex lens. Okay, so you can see in this image 90-degree plus diopter convex lens is used. The third method, it could be as optical coherence tomography. Okay, OCT. The next could be scanning lens calorimetry. Okay, and it is used for measurement of retinal nerve layers. Okay, important one, used for retinal nerve layer. The next is scanning layer tonometry, which is a normal anatomy of optic lens or optic disc measurement. Okay, so what is used? Scanning lens tonometry. Now the next examination is of angle of anterior chamber. Okay, so the angle of the anterior chamber which we studied, now the examination for that is done by oblique flashlight testing. Okay, in which the flashlight is thrown on the front of the temporal site. Okay, there the temporal iris gets illumination. Okay, it get illuminated, and there could be nasal iris get illuminated, or there could be a shadow over the nasal iris. Okay, and that would be a eclipse sign. Okay, here there would be an eclipse sign, and here there would be a nasal iris getting illuminated. Okay, if the nasal eyelids get illuminated, then the anterior chamber is deep and it is open angle glaucoma. Okay, this is an open angle condition. If the shadow over the nasal iris is seen, then this is an anterior chamber is shallow and this is angle close. Okay, the angle is closed. Let us see an image. So here you can see the light has crossed. Okay, and this is anterior chamber deep, this is open angle, and here you can see there is a shadow at the another place after the beam of light strikes to it. Okay, so this is angle closure. The next method which comes is Van Harkin's method, and it is done on the slit lamp using the oblique illumination. Okay, there is an oblique illumination over here. The peripheral anterior chamber PACD depth is compared to corneal thickness. Okay, remember this, PACT is peripheral anterior chamber and the CT is corneal thickness. These both are compared in this. Okay, peripheral anterior chamber depth, PACD, and corneal thickness. Now this is your cornea over here. You can see this is your iris in this orange color. Okay, and if this is the condition, this is an open angle glaucoma. If this is the condition in which the iris is closely attached to the cornea, then this would be angle closure. So in different grades, according to PACT and CT difference, there could be different things. Okay, different remarks can be given, like if it is more than equal to 1, the grade would be fourth and it would be wide open angle. Similarly these all. Now the best method is gonioscopy. Okay, and gonioscopy it works on the principle of elimination of total internal reflection. Okay, it works on total internal reflection principle. So that was all about the topic. In the next session we are going to study the POAG and PACG, that are primary angle open angle glaucoma.